Hello, hello, hello. How are you? How is everyone? Go ahead, let me know if you can hear me, and we'll begin in a moment. So, welcome to our new member, Teresa. Hello, hello, hello. So, I can't actually see who's all here, so I'm going to wait a moment or two. But in the meantime, I'm going to just kind of encourage you a little bit. Okay, coders, I see there are 13 of you here, and I'm ready to start. Are you? Okay, so this is what we call a 30-30. 30 minutes of instruction, and it's interactive, and 30 minutes of you doing your part. I'm going to give you a scenario, and you're going to go ahead and solve it, and you're going to talk to me in the chat. I'm going to help you through it. I think we're going to go over. Not because I was late, but because that I just don't know how to stay within 30 minutes. So let's get started. So the name of this instruction is called The Basics of Coding an ED Report, the AMCI Way. Now, I got to tell you, we do have a disclaimer. This course is not for beginners. All right. So this class is not for beginners, and you kind of have to have some stuff. You have to have a grasp of ICD 10-CM specific guidelines. You got to know CPT guidelines. You got to know HCPCS Level 2 guidelines. And just as a reference, if you're an MCDC student, those are our private platinum students, you should be in part 3. If you're an a la carte student, those are students that have purchased our courses individually. You should have completed parts 1, 2, and you should be in part 3. And YouTube students, you should have at least, at minimum, completed the first 12 weeks of our YouTube instructional course. All right. Hi, Aki. Great to have you. So just want to let you know that this is, an advanced course, and the goals of this presentation today, well, we're going to learn how to abstract codable documentation from an ED record. In other words, we're going to code an ED record. And I got to tell you, we are going to review the homework from last time. It was an operative report. We're going to learn the fundamentals of ED coding. We're going to talk about ED acuity points. This is some new stuff. We're also going to do maybe a quick, like a blip review of E&M, and we're going to do some practical applications, but we're going to do them together because the ED portion, because it's a little heavy. All right. Okay, so last week we learned how to code an operative report. We learned about the structure of an operative report. We learned what is codable and what is notable. We also learned that authentication is important and the guidelines always play a factor. Now, last class, I gave you some homework. So now let's go ahead and review it. But I want to remind you that when you are coding an operative report, remember that these items are not coded. You do not code bleed control or hemostasis. You do not code suturing or closure of the incision, the surgical site incision, except primarily skin procedures. So we do code for them for skin procedures. Don't code local or general anesthesia unless the surgeon is administering it. And I'm going to tell you, an operative report is the surgeon's report. So we're only coding for the surgeon. Do not code for draping and positioning of the patient. Do not code for irrigation of the wound exploration. That's minor wound exploration. If he's just looking around, don't code it. Don't code the dressing at the end, right? Don't code access to the surgical site. Don't code surgical drains. Don't code supplies. Don't code those things observed by the physician unless any of these are a part of the treatment. All right. All right. So this was your homework from last week. And I'm going to read it for those who weren't here last week so that we can kind of have everybody on the same page. And essentially, it's an operative report. The patient is Jonathan R. Ellis. Date of birth 3/14/1958. Medical record number 00482291. Date of procedure 8/25/2025. Surgeon Marissa Langston, MD. Assistants none. Procedure laparoscopic cholecystectomy. Anesthesia general endotracheal anesthesia. Preoperative diagnosis symptomatic. You know what? I cannot pronounce this word. Chole. You know what? I can't say it. I can't. And I've said it before this presentation, but I cannot say it. But we're going to say choleiasis, okay? Chronic cholecystitis. Those are the diagnoses. Postoperative diagnosis. Symptomatic cholelithiasis, chronic cholecystectomy, type 2 diabetes mellitus with neuropathy, hypertension, obesity, BMI with a 36.2, chronic or CKD stage 3. Indications for procedure. The patient is a 67-year-old male with a history of recurrent right upper quadrant pain, nausea, and intolerance to fatty foods. Imaging studies revealed gallstones and a thickened gallbladder wall consistent with chronic cholecystitis. Given the persistence of symptoms and increased risk of complications, surgical removal of the gallbladder was recommended. Operative findings: distended and thickened gallbladder dense adhesions to omentum and hepatic flexure. No bile duct injury, no intraoperative complications. Description of procedure. After obtaining informed consent, the patient was brought to the OR and placed in the supine position. General endotracheal anesthesia was administered. The abdomen was prepped and draped in sterile fashion. A Verus needle was used to establish pneumoperitoneum. A 10 millimeter trocar was inserted at the umbilicus. followed by placement of 3 additional trocars under direct visualization. Dense adhesions were encountered and carefully lysed using a combination of blunt and sharp dissection. The gallbladder was grasped and dissected from the liver bed. The cystic duct and cystic artery were identified, clipped, and divided. The gallbladder was removed via the umbilical port. Hemostasis was confirmed, the operative field was irrigated, and no bioleak was observed. All instruments were removed, and the incisions were closed with absorbable sutures. The patient tolerated the procedure well and was transferred to post anesthesia care unit in stable condition. Estimated blood loss less than 50 milliliters. Specimen gallbladder was sent to pathology. Complications none. Disposition to post anesthesia care in stable condition. Okay, coders. So you know what? Someone wants to join us. That's my Google. All right. So at the top right, you see this is my little cheat sheet. This is what tells me what I need to focus on, right? I need to focus on the post-operative diagnosis. I need to focus on the procedures performed, the indications for the procedure or the history. This is the history of that illness. You could get some things from this section. The operative findings can confirm some things. Anesthesia, was it administered by the surgeon? Also, authentication. Was this report properly authenticated? Okay, coders, that's my question to you. Was the report properly authenticated? That's right, Devonna. She said, let's go AMCI. That is right. Was this report properly authenticated? If you were here last time, you will remember how to properly authenticate. I'm going to give you a moment or two. And while you're thinking, I'm also going to check to see if there was image guidance or anything else that I might have forgotten. All right, no one marked in the chat saying that it was properly authenticated. Maybe someone just did. All right, but what is proper authentication? Number one, at minimum, the first initial, last name, and their credential and date. Well, it does not say that it was signed. Usually it'll say signed, and you'll see their first initial, last name, and the date. Now we see it's located here. It's just telling you that this is the surgeon. It's telling you that this is the procedure date, but this is not the signature. So it will have a separate entry and it will say signed typically. So this operative report is not signed. So guess what? We don't code this, but we are going to code it today, right? Never code anything that hasn't been authenticated. Send it back to the doctor. All right. So on the bottom right, these are my keywords that I pulled out. And I'm going to get my little pointer just for just a moment. And we have a laparoscopic cholecystectomy. We have symptomatic, you know what? Cholelithiasis, okay? Chronic cholecystitis, type 2 diabetes mellitus with neuropathy. You have HTN, obesity, CKD, stage 3, BMI. Anything else? Did I forget anything? Did I forget anything? Does anybody see anything in this operative report that may have been missed? Well, let's continue. And if you feel free to put it in the chat if you see anything, because I could have missed something, right? So what I'm going to do is I'm going to just box my codables, things that I know should be coded, like this laparoscopic cholecystectomy. Um, I'm going to code the postoperative diagnosis, and it's only well, this physician put all of the postoperative diagnoses in one section, and we're going to code them all because they are present at the time of this encounter. We have this symptomatic chronic cholecystitis. We have the type 2 diabetes mellitus with neuropathy, hypertension, obesity, and with the BMI, CKD, and stage 3 CKD, coding it all. Also, see my little purple boxes last time I told you? Those are my notables. I'm just going to note the history of this illness. Also in here, we see the patient's um, signs and symptoms. And we know we don't code signs and symptoms if they are integral to a disease. So feel free to take a look in this section. If you can find something else that I may have missed, it's okay. Just let me know. We can adjust very easily. Also, I'm skipping over the operative findings for now, and I'm going down into this description of procedure. I'm putting a notable box around this 10 millimeter trocar inserted at the umbilicus, and also these 3 additional trocars under direct visualization. The reason why this confirms to me that this is a laparoscopic procedure. Well, it's an indicator of a laparoscopic procedure. Also, I'm going to note that there were dense adhesions. I'm also going to note again that the gallbladder was removed via that port, that umbilical port. That's confirmation that a laparoscopic procedure took place. And why do I do this? Because you could get caught up when you're coding. It's very easy to forget, like, hey, this is a laparoscopic procedure, and maybe accidentally code a non-laparoscopic procedure. It's very easy to do that. There's a lot of words here, and it could happen. So just want to point out in this notable section, I boxed it because this confirms why the procedure took place. And it could house some more clues about the procedure. Also, this box here was evidence of a laparoscopy, and this box here, this confirms that this is a laparoscopy. Now, over here were the dense adhesions. Could we use modifier 22? Could we? Go ahead. What do you think? Do you think this is increased procedural service because the doctor documented that there were dense adhesions? Just a thought. Just a thought. All right. So just want to know, I just kind of want to move along because this is homework. At the top, my first listed code will be the calculus of gallbladder with chronic cholecystitis without obstruction. The secondary diagnoses that I'm coding, I'm going to code E11.22. This is diabetes mellitus type 2 with CKD. I'm also coding end-stage CKD, not otherwise specified. He didn't specify the stage of the CKD, like they further classify them A, B, C, etc. So that's why it's NOS. Also, I coded E11.40 diabetes mellitus with neuropathy. Also, I-12.9 hypertensive CKD because the hypertension and CKD were present in the same encounter. And obesity, E66.9. Also, they did say that this patient had, let's see, had a BMI of 36.2, which is down here. And then the primary procedure, 47562 22 modifier. I ruled against 22 modifier because the doctor didn't although the doctor said they were dense, but the doctor didn't say that there was any degree of difficulty. So you can't say that there was increased procedural service, right? Yeah, outstanding. Alex nailed that. But finally, here are the final abstracted codes. K80.10, my E11.22, N18.30, E11.40, I12.9, E66.9, E and Z68.36. That's the BMI. And the CPT code has no 22 modifier. Okay, coders, if you have any questions about the homework, go ahead, type in the chat. Now, if this is kind of advanced for you coders, it is advanced. This is for the coders that have been coding a little longer and they have a command of the guidelines. They know to code diabetes mellitus. They know to code as many diabetes mellitus codes that are applicable. They know to code the hypertension and CKD as hypertensive CKD. They know to code the obesity. They know to code the BMI. All right. And we're going to talk about BMI because they have those classes now. And I'm just going to let you know what the guidance is just so you don't think you have to code for the classes yet. All right, so now it's time to test your knowledge. We're going to do this again. Yeah, we're going to do this again. You know what? I don't know if you like this inventory over here. I may have given it away. Hmm. You know what? I'm going to do it anyway. This is a hmm, hmm. Coders. I apologize. I think you know what? I hope I might have to reshare this, but I don't want to show you the answers. I don't think it's fair to you. Okay. So give me a moment. And if you have any questions, go ahead and type them in the chat. And I think I'm going to redo this. I got to reshare this, but I can still see you. Just want to see. Just want to make sure that we're all straight. Yes, it's ready. Any questions? I don't see any. You all are doing an amazing job. I want to remove this. I want to stop the screen. Then I'm going to share it again. One moment. It's trying to share the old screen. So let me just get it. Thank you for your patience. Okay, so you should be able to see my screen again. Let me know if you can or can't. And someone has a great question. It says the guidelines. Exactly. The guidelines instruct you on what you need to do. Someone said they're new. Absolutely. So when you get to part 2, you're going to learn all of the specific coding guidelines for each disease. There are 22 chapters, so you're going to learn them, and you're going to see them over and over. Wait, I thought I fixed this. Is it? Let's see. Sorry. Hmm. All right, I'm going to try it again. Hmm. That looks kind of small. Let me fix it. All right. So I'm not going to fool around with it anymore, and I'm just going to use what I currently have just so we can get started for time's sake. And I do thank you all for your it just appears that I have a couple of tabs open. All right, so now you should be able to see my screen, and it should say test your knowledge on that screen. Let me know. Oh, it's fixed. Yay. All right, let me know if you can see my screen, and then I'm ready to rock and roll. Awesome. Okay, here we go. So this is our new scenario. And if you're having difficulty viewing, go ahead. There's a broken square at the bottom. Click on that broken square and it'll bring it up nice and big for you. And let me know if that works. All right, so we have Walter Lennox, medical record number 3333333, date of surgery 8/21/2025. Surgeon Tanya McCollum, MD. Assistant Reginald Bantam, MD. Anesthesiologist Joanne Jefferson, MD. Preoperative diagnoses. Sigmoid colon adenocarcinoma with obstructing mass with partial large bowel obstruction. Postoperative diagnosis is the same. Procedures performed. Open low anterior resection of the sigmoid colon with primary anastomosis. Resection of small bowel segment with anastomosis due to intraoperative injury and ischemia. Omental flap reinforcement. Anesthesia, general endotracheal anesthesia. Estimated blood loss, 900 milliliters. Complications, intraoperative serosal tear of the small bowel, resected with primary anastomosis. Specimens removed, sigmoid colon with mass, segment of small intestine, omental flap sample, disposition, surgical ICU for monitoring. History and comorbidities. The patient is a 67-year-old male with a history of type 2 diabetes mellitus, insulin dependent, CKD disease, stage 3 hypertension, coronary artery disease, status post stent placement 3 years ago, on aspirin. AMI, acute myocardial infarction 3 years ago. Chronic obstructive pulmonary disease or COPD, obesity with a BMI of 37. He presented with abdominal pain, constipation, and weight loss. CT abdominal revealed an obstructing sigmoid colon mass with proximal bowel dilation. Colonoscopy confirmed adenocarcinoma. Given the obstruction, surgical resection was planned. Operative findings. Large circumferential sigmoid mass calling partial obstruction was identified. The small bowel was markedly dilated. One segment showed ischemia and was resected. Omental flap was mobilized to reinforce the colorectal anastomosis. Description of procedure. After informed consent was obtained, the patient was brought to the OR and placed under general anesthesia. A midline laparotomy incision was made. Exploration revealed an obstructing sigmoid mass. The sigmoid colon was mobilized, resected, and a primary colorectal anastomosis was created using a circular stapling device. During mobilization, an intraoperative serosal tear and ischemic small bowel were identified. Approximately 20 centimeters of jejunum was resected, and a staple side-to-side anastomosis was performed. An omental flap was mobilized and tacked over the anastomosis for reinforcement. Hemostasis was achieved. Drains were placed, and the abdomen was closed in layers. The patient tolerated the procedure and was transferred to the ICU in stable condition. Surgeon's signature and date. Okay, coders. So you see that this was authenticated so we can code it. Now, I want to know. Well, I'm going to show you my inventory list first. I'm going to highlight or box my codables, then my notables, and then I'll show you my list. All right, so I'm going to code all of the preoperative diagnoses. I'm going to code the procedures performed. I'm going to code this intraoperative serosal tear. So they did a little nick while they were operating, and that is common. I'm also going to code any comorbidities at the time of this procedure. And I'm making note of this. This is significant. It says, given the obstruction, the surgical resection was planned. So the obstruction is the reason that they had this procedure. Just saying, but it is not going to be my first listed. Now, the operative findings. Here are my notables. The omental flap was mobilized to reinforce the colorectal anastomosis. The sigmoid colon was mobilized and resected, and the colorectal anastomosis took place. Then about 20 centimeters of the jejunum was resected and anastomosed, and that omental flap was mobilized and tacked over the anastomosis. So those notables help me understand what took place. And you're going to see how I process this in the next slides. But right now, my diagnoses, and I'm speaking a little slow because if you have a different diagnosis or you found something else that I may have missed, then, or chat may have missed, because chat did generate this scenario, but they coded it all wrong. We were tugging away at this. So you, if you find anything else, let me know. But your task is this. You need to provide all codable diagnoses. You need to distinguish the first listed, and you need to code any procedures and any modifiers. That's your task. So, my diagnoses: sigmoid colon adenocarcinoma. Number 2, the mass causing the partial large bowel obstruction. I'm going to code that. I'm going to code this serosal tear, diabetes mellitus type 2. And I got a lot of these comorbidities right here. I'm going to code the insulin, the long-term use of the insulin. I'm going to code CKD stage 3. I'm going to code hypertension. I'm going to code coronary artery disease. I'm going to code the personal history of status post stent. They had a stent placed 3 years ago. I'm also going to code the long-term use of aspirin. I'm going to code the old myocardial infarction 3 years ago. I'm going to code COPD, obesity, and that BMI. I'm going to pause. I want to make sure I'm not, if you all want to talk, go right ahead. And if you're, and if you can kind of keep your discussions on this question right now, but after that, you can say whatever you want. And I'm going to go up and look for your older discussions too, your older questions. All right. So, of these diagnoses, which one is your first listed code? Go ahead, type in the chat. Which one is the one that we are going to sequence first? I see some answers coming through, Carnell. That is right. And if you know what, you all can just, you know what, don't be afraid to put an answer that's different. Don't. All right. So I kind of gave it away. But the answer is sigmoid colon adenocarcinoma. And here's why. Even though the obstruction is the reason that they went in to have surgery, this obstruction is related to this sigmoid colon adenoma carcinoma, right? Yeah, it's related. So we're not going to bundle it. Yep, exactly. Yeah, it could have been caused by this. So we're not going to bundle it because this is the reason they planned the surgery. So we're going to code this as well. So this should be a teachable moment as well for you. So number 1, the cancer is your first listed code. And does anybody have anything else that they want to add to this list? Yeah. And also, yeah, somebody said we're going for the root. I don't know if you're talking about the manifestation. So this um, obstruction is a manifestation of the adenocarcinoma, I think. I think. All right. So if there's anything that I may have missed, please type it in the chat. Now let's focus on the procedures. We have resection of the large bowel with anastomosis of the sigmoid colon. I got that up here, right? The resection of the small bowel with anastomosis, that jejunum was resected, and the omental flap reinforcement took place. So they enforced the anastomosis of the large bowel. Now, I'm visual, right? I'm visual. So this is what took place. And those notables really helped me figure out what happened. I'm not a surgeon, I'm just a coder. So we had sigmoid colon resection with anastomosis. So they resected part of the sigmoid colon. There is your, let's say, your obstruction. They cut it. That's your resection. And then they sewed it back together. That's your anastomosis. And I got that information right here. Next, let's go to the next. I want to get rid of this pointer. The next procedure, they resected the jejunum about 20 centimeters and then they stapled it side by side. All three of these images are examples of resection of the jejunum and a anastomosis. So they were anastomosed some kind of way. However, sorry about that. This is my stapling. They did a side by side anastomosis, and it could have been any one of these procedures. So that also took place. Also, they talked about that omentum. They use the omentum as a flap. And what is omentum? Well, that's the fatty tissue that's located between the small and the large bowel. And what they did, well, according to this documentation, the Omento flap was mobilized and tacked over the anastomosis for reinforcement. So basically, they took this fatty tissue and pulled it over the anastomosis to reinforce it. And that's what took place. So that is my procedure. Now, coders, we don't have time to look up all these codes, and I want to. But these are my final diagnoses. Number one, the sigmoid colon adenoma or adenocarcinoma, excuse me, the big difference. Then there is a code for partial large bowel obstruction. Then intraoperative serosal tear of the small bowel. Yes, this is a complication code. Also, type 2 diabetes mellitus with CKD, long-term use of insulin, hypertensive CKD, chronic kidney disease stage 3. So both of these are going to be coded. You know, the presence of CKD and HTN changes it to hypertensive CKD. The CAD, coronary artery disease, history of stent placement. I also coded the old myocardial infarction, the COPD, obesity, the BMI of 37, and the long-term use of aspirin. Yes, maybe that's what someone's saying in the chat. Maybe the history codes. Absolutely, we did code it. And just for context, I want to tell you, I see a lot of people saying, "Hey, I'm creating scenarios with AI." Be careful because they're really not, they really can't process all of the guidelines at once. They do a good job, Generally, for maybe smaller ones, definitely the operative report. And I'm going to tell you specifically where they got it wrong. The partial large bowel obstruction, they did not code this correctly. They used a more generic code. This one was better because it specifically said partial. Then one of the chats that I used didn't even code this intraoperative tear. Also, this diabetes mellitus was not coded as a combination code. They just coded diabetes mellitus and they coded neuropathy separately. This one of the chats did not code long-term use of insulin. The other one did. Neither coded the hypertensive CKD. They just coded it as straight C, hypertension. And what else was missing? And one of them also added a different code for this tear. It wasn't even the complication. So be very careful. That's a high number of error. So don't definitely create small scenarios, and they're still going to probably get a lot of them wrong if they involve guidelines. So if they're not guidelines, then you're safe. And we use AI. All right. So, with that said, if you have anything you think I may have missed, if you want to screenshot, go ahead and screenshot it and look it over. And then you can come back next week and say, hey, this was wrong. I got something else, or email me. I love it. I would love it. Now, let's go to the procedures. We have open low anterior resection, primary anastomosis. So pretty much this open low anterior resection is their cutting of that, the colon, and the colon, the sigmoid colon, 44146. Then they're coding for the jejunum, the resection of the jejunum along with anastomosis, and that's 44120. Then there is omental flap reinforcement, 49905. I like these three codes. So if you all saw a lot of words in that operative report, you might see a lot of repetitive words. So don't let it intimidate you. They're all saying the same thing. Do whatever you need to do to break down that operative report so it makes sense to you. And it pretty soon you're going to get it. You are. So these are the codes, and I do agree with them. In terms of modifiers, I do think modifier 59 should be placed on 44120 because this is the small bowel. It's not the same body part. It's a different body part. So 44120, 59 modifier, different body part, different procedure. Also 49950, 59 modifier, different body part. This is the omentum, different procedure. And this is my final answer for the procedures. So coders, how do you feel? Go ahead, talk in the chat. And you know what? We've been live for about 50 minutes. Yeah, someone said, hey, is that intraoperative serosal tear an accident? Absolutely, it's an accident. Now, if you're coding for the facility, trust and believe that facility is not, the doctor may not get paid. The facility definitely won't get paid because we have a way to let them know that that injury was not present on admission. So facilities do not get paid for things that are present on admission, especially that are not present on admission, especially if it's an injury. Yeah. Okay, so that was a good question. And I also want to tell you about this obesity class. In 2025, ICD-10-CM included these obesity classes. So these obesity classes require a fifth character. So they're 5 characters long. Well, no, 6. Look at this. One, two, three. That looks like 6 characters to me. But it requires a fifth character, one, two, right here, to convey the severity of the obesity. So these obesity class codes say how severe the obesity is, but that severity must be documented by the provider. If it's not documented, then you cannot code it. And AI was even coding it. And I'm talking to AI. I'm asking them where in the documentation did the provider specify the severity of the obesity? And AI is telling me that they're saying that it's severe, and I understand that, but we have to code what the doctor says. So be careful with your AI, and I would just say stay small. Get those basic ones, right? If you just want to create some, but you don't have to. If you have your MCG manual, you've got over 1,000 scenarios that have been vetted. All right, so coders, I just got to tell you, I'm going over. So if you have to leave, go ahead. I encourage you to watch the playback. Go to the AMCI channel and click on lives. You'll see this playback. And I'm going to edit it too. That segment where I was searching, I'm going to edit it so you don't have to, you know, fuss with that. Now, I want to talk about coding for, and great job, everyone. You know, we're going to do more. So don't feel like, oh, you need more practice. We will do more, but it's important right now that I get this instruction in. Okay. All right. So, coding for the ED facility emergency departments. Coders, we are coding for that facility. You all are familiar with the E&M coding, right? E&M codes for the professional. However, the ED facility or the level of service is coding for the facility. It's coding for that ER, right? What is the big difference? Well, we know the E&M is coding for the provider, but the facility is coding for the resources used within that facility. Okay, so all these things. And how is it done? How is it done? Well, we assign a level of service, assign a level of ED facility, right? So it's either level 1, 2, 3, 4, and 5. And if you look here, you can see that they share the same evaluation and management code. It does. And I'm going to tell you, remember, when you are a professional coder, you are an outpatient coder. And some providers expect you to know ED. If you work for a facility and you're coding for outpatient facility, ED is outpatient facility, so let's go ahead and learn. And oh, I got a disclaimer. This is not on the professional exam. No. So if you are like, you know, studying for the professional coding exams hot and heavy, please don't take this serious. However, if you're CCS, this is on your exam. So if you want to get a glimpse to see what CCS is, here you go. Now we code for the ED facility and they use the same evaluation and management codes, but they have level 1 through 5. Level 1, minimum, minimal, level 2, straightforward, level 3, low, level 4, moderate, and level 5, that's high. Now, in order to code for this facility, you're going to need some guidance. And the CMS has created some factors that you need to use, and they allow entities to create their own way to measure. And this is an ED acuity chart that was created by AMCI with the CMS guidelines and the American Emergency Physician Association. I can't call that acronym, but please forgive me. But we use these guidance, and it's also in accordance with AHEMA. And essentially, this is the chart. We're going to take a look at it in a minute, but I wanted you to see it up close and personal. And this acuity chart measures 4 things. You will need to answer the following questions: the number of medicines given during the encounter, not the medicines prescribed, but the medicines administered, the degree of the MDM. So in other words, you're going to need to know the E&M MDM. You need to know the number of tests ordered and the number of supplies used. And based upon the amounts, you will use this acuity chart to help you identify the level of service. So essentially, a level 1 is between 1 and 20 score, level 2, 21, 35, level 3 is 36 through 47, level 4 is 48 through 61, and level 5, that's greater than 61, and critical care is greater than 61 with constant physician attendance. And then these are your general corresponding CPT codes. But in our case, this is it. These are our CPT codes. Now I'm just going to show you. I'm going to show you how we quantify using that AMCI acuity chart. All right, so we have a 34-year-old who presents to the ED with ankle pain after a fall. Nursing triage includes vitals and splint application, facility resources, x-ray of the ankle, lab draw for CPC, oral pain medicine administered. Patient was discharged with crutches. The MDM for this encounter was low. Of the following answers, which best describes the facility encounter? So we got a code for the facility. This is a facility report simulated. And we're going to use this acuity chart. And we got to answer the questions. Let's just do it. What are the number of medicines given during the encounter? The medicines that were not prescribed. Go ahead, type in the chat. How many medicines were given? Good. Somebody said oral pain medicine. That's all I see. I only see one, right? One. Okay. What is the degree of the MDM? And we're talking about the E&M MDM, the doctor MDM. Anybody know? What's the degree of the MDM? Is it none? Is it straightforward, low, moderate, high? Okay, well, the documentation says, I'm going to give you another opportunity. If you look at your documentation, the documentation says the medical decision making for this encounter was low. Low, right? So it's low. Now, the number of tests ordered. How many tests were ordered? Good job, BB. I see you. And good job. You know, Alex, I know you said you are a novice. You are doing a phenomenal job. Phenomenal. That's right, Chantel. That's right, Alex. You are rocking it. So the number of tests ordered are two. Had an X-ray of the ankle and a lab draw for the CBC. Now, how many supplies were given? How many supplies were used? Excuse me. Well, it says that the patient was discharged with crutches. So we have one supply. So this is basically how you quantify. That's right, Alex. All right, so now we're going to go to our chart, and I'm going to start with the number of meds given. We said it's one, so one falls right in here, and I'm going to, sorry, we're going to do it right here, so it's bigger, okay? So the number of meds given are one, so it falls right there. Also, the degree of the MDM is low, so it falls here. The number of tests ordered were two, so the number of tests falls here. And the number of supplies is one, and that falls here. So I'm going to let you process this chart. So the number of meds given falls here. The number of supplies used also fall here. The degree of the MDM is here, and the number of tests ordered are here. So now you got to add it up. So you add the columns. So in the first column, you got 5 points for the number of meds given, 5 points for the number of supplies. 5 and 5 is 10. You also have 10 points in this column, and the only thing we have here is the number of tests ordered. So that is going to be plus 10, and the MDM is 15 because it's in the 15 column. So you have a total of 35 acuity points. Now we got to go grab our code. And what we do is we take our total and find the total on this lower row. And our 35 falls right here. And if you look down, this is the code for a level 2 facility, 99282. Encoders, that's your answer. 99282, level 2 ED facility. Okay, coders, so this was supposed to be a 30-30, and I do apologize for the extended time, but I wanted to get that instruction in, and we're going to begin next week. We're going to pick it right up, and we're going to go ahead and code an ED report using this acuity chart. And let me see if I can give you, I want to just kind of summarize things. All right, so in coding this ED facility, you're going to have to evaluate the documentation, those 4 items, the number of medicines, the degree of MDM, the number of supplies, and tests. Then you add it all up, you locate your code on the chart. And that's how you get the ED facility level of service. Now, next time we're going to code an ED chart. Now, you got some other things to do. You have to code everything. You're going to have to code your first listed diagnosis. You're going to determine your secondary diagnoses. You're going to determine your E&M level of service because you're going to need it when you do use your acuity chart. So you're going to do 1, 2, 3, 4, and we're going to pick it up next time. All right, so I'm going to just take a moment to take any questions that you might have in the chat, and I'll stay here as long as you need because it's not fair that I took up your 30 minutes. And I want to thank everybody. I want to shout out my team too. Miss Yadira, I see you. Thank you so much. Ms. Mills, thank you. Ms. Mills is doing something else and she's in here simultaneously. I want to thank you. And I just want to thank everybody. Um, just for putting forth your best effort. And even the newer coders, if you're trying this, keep at it, stick with it. Stick with it. It will click. Isn't that right, Ms. Mills? Hi, Nina. Welcome back. She came back from last week. And Alex, please come back. But I do want to let you know that coding the ED chart is specifically for the CCS exam. And if you're taking the CIC, I don't know. I don't have my credential in CIC, so I'm not sure what's on that exam. It may or may not. But in the real world, this is real world coding. So everyone, if you want to work in the ED or for a facility and code ED records, this is going to be applicable. All right, any questions? I'm going to answer them live. Now, someone said CCA. CCA, we don't prepare you for the CCA. We prepare you for the CCSP. And I want you to think about that. Think about getting your CCSP because CCSP is a mastery, and the amount of work is, the amount you're doing for your CCA, you can just go ahead and get your CCSP. I'm not sure. If that's something in your wheelhouse, but definitely think about it, do your research, and it's well worth the time spent. All right, so someone said they're taking their exam this month, but not sure exactly what to take. Well, you got to kind of figure out what it is you want. If you want to be a professional coder, CCSP or CPC, that is what I recommend. I'm kind of telling people to take the CCSP because of the apprenticeship that you get when you are taking the CPC. If you don't have experience, you're going to be an apprentice, and you need 2 years experience or that education or internship, and a lot of people get stuck there, and I'm saying might as well get your CCSP because you're not an apprentice. Same with CCA, you'll be an apprentice. So if you want to start working, a lot of people don't accept CCA or CPCA. More people take the CPCA than the CCA. I just have to be honest. Hi, Tahimina. Welcome, welcome. If you all have any, somebody said it's too many letters. Yeah, it is a lot of letters, but do your research. Go to the AHIMA website, go to the AAPC website, make yourself familiar. It is a lot. My job, and I'm very dedicated to it, is to make sure you're prepared for those exams, right? That's what I do. And I try and give you some additional things like this, so even though this is preparing you for the CCS exam, this is also going to prepare you for the real world. Someone said, yeah, I want to start working. If you want to start working, then make sure you have a certification that's not an apprenticeship unless you have experience. If you have the experience to get it removed, then you're good. If you don't have that experience, I say go for the ones that don't give you have the apprenticeship requirement. However, if you enroll in certain courses or take the AAPC Practicode, you can take their Practicode and they'll remove the A. But some people just, say, they're weighing out costs because there's a cost assigned to the Practicode. I don't know if it's $300 or $500. I'm not sure. They change their prices all the time. So definitely go to AAPC Ask. Okay. And they also have lots of scholarship They used to. So check with AAPC and see if they have a scholarship for the Practicode. Someone said they're preparing for the CCS and the videos are helpful. Outstanding, Britters. Um, my advice: go make sure that you are you watching the PCS videos. Those PCS are really helpful. They are introductory, but they're a good start. And are you using your Chison book? That's also great. Yeah, Alex, you can do it. If you have I say get a good mentor. Get a good mentor. They're going to tell you what to do and how to avoid all of the loopholes. Yes, there are you if you don't do it the correct way, you could spend a ton of money, right? We know that. That's why we have the free course for you. Um, and some instructors, I got to say, instructors, are you listening to me? If you're listening to me, you got to do your work. You got to do the work. You have to study. A lot of these instructors, and I'm not talking about the long term instructors, I'm talking about the people that just passed their exam. They just passed their exam and now they want to teach other people. Stop doing that. You got to do the work. These students are spending an incredible amount of money. So I know people are listening to me. I know that a lot of people within the industry hear me and they watch me. I know. Listen to this. If you just passed that exam, and I'm saying just within the last 3 or 4 years, you are new. You have to do the work and you are costing these students. And that's why I'm offering these free courses. All right. I'm back to you all. Do you all have any questions? And the reason I'm speaking to them is because there are things they need to learn. Here's the first thing: there are multiple types of learners. The way you learn is not universal. So you have to be able, I'm talking to the student instructors, the people who are new instructors, you have to be able to speak to everyone and you have to study. Study. Okay, I'm back. I'm back. You're welcome, Carnell. All right, everyone. So I'm going to end this stream, and I want to thank all of you for coming. Next week, we're going to code out these ED charts, and we're going to code a couple of them. And also, I'm prepared to look up codes in real time. If you all want to challenge anything or think that there's a better code, I'm going to give you more time so you can look up things and we're going to um we're going to do this together. All right. You are welcome. You have a great day, Nina. You too, T. You're welcome, Alex. All right. Thank you, Carnell, again. And everyone, have a fantastic rest of your day.